Hi, good afternoon, and welcome to the summer edition of the Children's Cause for Cancer Advocacy webinar series. My name is George Dahlman, and I'll be your moderator for this session. This is the latest in a series of webinars hosted by Children's Cause to inform and mobilize childhood cancer advocates. Today's edition is an update on several advocacy initiatives that have taken place and several that are still ongoing that should be important to members of the childhood cancer community. Before we start, I'll go over some reminders and housekeeping items as we usually do in webinars. If you need any technical assistance, you can dial 202-487-3270. That's 202-487-3270, and Jessica Keene on our staff should be able to help you. I will remind you, today's call is being recorded and will be available on our website at childrenscause.org. And even though there are people listening now, we frequently have quite a few people that catch up on this and watch it again later on. We're joined today by three distinguished panelists, each of whom has been very instrumental in working on initiatives that improve the care for children with cancer and survivors and their families. We're hoping that the format today will be just a review of some things that we've recently done and where they stand, and then we'll move on to some other items that are in the works with the community. During the course of the webinar, everybody's on mute, but of course we encourage you, if you want to add questions on the box, the question box on the side on the right of your screen, please do, and we'll get to those at the end of the presentations. At the end of the webinar, also, you'll be automatically redirected to a post-webinar survey. And if you could, take a few minutes to answer that, because that gives us some idea of how we're doing and how we could improve on these in the future. They've already helped us quite a bit. As I mentioned, we have with us three experts in their field to help understand some of the campaigns that have been going on in our community. Amy Osmond from the Children's Hospital Association will go over the ACE Kids Act, which was recently signed into law. Tyler Hansen with the American Society of Clinical Oncology, ASCO, will guide us through the Clinical Treatment Act, which is now pending in Congress. And Dr. Monica Gramatkes of Texas Children's Cancer Center will describe a very well-respected and successful program that helps childhood cancer patients transition to survivorship. One of the things that I wanted to go over first really has to do with the kind of the children's cancer community and advocacy community at large. And where we stand with it, as we all know, because we're all working on it. The STAR Act passed Congress last June, and this was a really long campaign and a long sought after goal by most of the community, because it combined a lot of policy objectives of a lot of different groups. And so even in the formulation of it and also with the passage of it, it was really much a very community team effort. And it called for a number of things like biospecimen collections, the cataloging and coordination and the infrastructure for that, a cancer registry infrastructure at CDC. CDC already does a lot of these for different diseases. So now that would also include childhood cancer. And importantly, for a lot of us, research into the care and quality of life for survivors, and some additional care provisions having to do with the workforce. Since it was passed, you may be familiar, many of you are probably familiar with the Alliance for Childhood Cancer, which is the main coalition, the policy coalition of the community at large. And most of the groups, including ASCO, are members of that. We have a number of task forces that are looking at these different components and trying to make sure that the federal agencies are on track with them, and that we can provide any assistance or expertise from our own perspectives. And actually, a number of things have already started with this. The NCI at the beginning of this year put out a request for application to develop interventions for childhood cancer survivors, both the physical and psychosocial parts of that, but also in the delivery of care too, in healthcare delivery, and also to prevent or mitigate adverse effects. And also on another component, on the biorepositories, just last month, there was a meeting of experts in different organizations who already have biospecimen repositories, and they were trying to reconcile the challenges and opportunities to how they could coordinate what they have. So there is progress being made on some of these things, but it's going to take a number of years, and of course a little bit of money too. And that's where we come up to something that a lot of us in Washington watch pretty closely, and should be of concern to most of the community. To get any of the STAR Act finished or moving along is going to require some funding. STAR was slated to get, or is slated to get, $30 million a year. That, of course, is dependent upon the funding that Congress decides to get to NCI. So the work of the advocates is never really done. We took several years to get the STAR Act finished, and now we'll have to advocate every year to get more funding to have it fulfilled. So a snapshot kind of where we are at the moment as far as appropriations is the House of Representatives has passed an appropriations bill. It was really, I think, 2 months ago, for NIH, which with an increase of $2 billion over the current year's funding, and an increase for NCI of over $300 million. And that included, you may recall the President in his State of Union address suggested $500 million over 10 years. So NCI has identified $50 million for this year for a childhood cancer data initiative. And that's available on their website if you want to take a look at the description of it. The question of the $30 million for the STAR Act is still up in the air. We'll certainly be encouraging members of Congress and NCI to make sure that that money is included in the NCI budget. But the important thing right now is that the Senate has not yet acted, and may not act ultimately, which will complicate things for us. But you can take matters into your own hands and help move this along. We have an action alert at our website at childrenscause.org in the Action Center, and you can go to find a pre-done letter and the ability to send it directly to your senator in this case, to encourage them for full funding of NCI to fulfill the STAR Act. One of the other recent accomplishments for childhood cancer in our community was the Advancing Care for Exceptional Kids, or ACE Kids Act, which is important for our community because about 1/3 of kids are covered by Medicaid, and also most kids who have cancer are referred to major cancer institutions. They're not treated in the community. And so frequently they have to go across state lines for treatment. So we have with us today Amy Osmond from the Children's Hospital Association, which spearheaded this entire effort. And we were along for the ride, but it was a very important effort and successful. And I'd like Amy, if she can, to give us a background on it. Amy?
Thank you, George. And I'm very happy to be here with all of you to talk about the ACE Kids Act and to have something positive to talk about. I know you all are working on many different initiatives for children with cancer, and you all were great advocates for the ACE Kids Act as well. So we want to, first of all, thank you all for your efforts. It was a multi-year effort. As you all know, things don't happen very quickly here in DC. So we want to kind of go over where we are on the ACE Kids Act. It obviously has been enacted and signed by the President, passed by Congress recently. Then also talk about what our next steps are. As you know, it's not, the end of the story is not when the bill is enacted. There's a lot that goes into the implementation to make sure that we are being successful and that the law is successful. The goal obviously is to improve care for children with medical complexity, including children with cancer would be included in that. And so we want to make sure that we see that actually happen as we look for implementation. So today, I know we have multiple topics that we're covering on this call, so I'm going to hit at a high level some of the highlights of the final bill. As we move through the legislative process, there were changes along the way. So just to make sure everyone has the same base knowledge in terms of what the law says and what we'll be looking for in terms of implementation. We'll talk a little bit about the timeline we expect for implementation, and then at the end of the call, we'll take any questions or comments that you all want to make or discussion you'd like to have. George, I'm having a little bit of trouble moving this. There we go.
There we go. I can do that.
Perfect. So just as a reminder, the law was signed on April 18th, and we had many strong champions who supported and pushed for the ACE Kids Act, and we're doing a lot right now to thank these champions. Actually, just today, we had a lunch with children's hospitals and families from all across the country who had come in for an advocacy day, and we did a lunch to thank all of our congressional champions who stuck with the ACE kids over several years and really pushed hard to get it enacted. And they're very keen to see this be a successful effort, and they'll be our partners as we look at implementation as well. Moving to the next slide.
Yeah, if we can get it to move. There we go.
Perfect. So this is just a quick slide to cover the strong and widespread support for the bill that we had, including your organization. And we'll be working with all of you and these partners at the federal level as we look to influence how the bill is implemented at the federal level, but also these will be partnerships that will be formed at the state and community level as they look at how can they participate in the ACE Kids Act.
Mm-hmm.
This slide just shows, the next slide just shows a kind of overview of the multi-year, multi-Congress effort. You all work in this, so you know that these things don't happen quickly, but it's just a reminder of how many Congresses the bill was live in and how long it took us to get to this end point. Moving forward to the next slide. So just to cover some of the main provisions of the law. So what the law does is it creates health homes tailored to children with medical complexity. And health homes is just another term for medical home. So it would be a group of providers that would be working together to better coordinate care for children and their families. It would be voluntary for states. So the states would have to, state Medicaid programs would have to opt into the program to participate. Children and families can participate or not. It's their choice. And providers as well. It's their choice if they want to participate. In the legislation, there are state incentives. So to try to influence state decisions, they put some incentives in so that there would be some enhanced federal matching funds for them within their Medicaid program to help pay for some of these health home services that the health homes would provide. That would be over 2 quarters, have those enhanced federal matching funds, and there would also be some planning grants to help states get started in this endeavor. The bill also requires data and quality measure reporting for the states, but also for the health homes. And that was one key aspect of this bill, that we wanted to make sure that we would get new and better and more consistent data on children with medical complexity, so we can see where there are gaps in care, and also to figure out what would be the most appropriate payment models for this population of kids. What kind of care do they need, and what kind of payment models would be most appropriate? The bill would also allow states to work with their health homes, with these health homes, to establish new payment models. Right now, in many states, if you do things to keep the child out of the hospital and closer to their home and in their community with better supports, there isn't a lot of financial support for that. So we're looking to better align how Medicaid pays and the best outcome for this population of kids. And last but certainly not least, the legislation includes a national definition for children with medical complexity, and we'll get into that in a little more detail in the next slide. So here you can see kind of the legislative technical language on the definition of a child with medical complexity. We modeled it using the 3M clinical risk groupings, and in that model, it would include children with cancer and other children who have complex conditions that affect 3 or more body systems. But we modeled it in a certain way. Now we need to see how CMS will operationalize this definition. This is just a legislative definition, and we need to work with CMS and the Secretary of HHS to kind of put some parameters and guidelines around this definition. We would like to see as tight as possible of a definition so that there's not tons of flexibility in each state to interpret this the way they would like, because that will stop us from getting that good and consistent data that we really want to be able to see across states on this population of kids. So we'll be working with CMS and hopefully partnering with you and with other organizations so that we can get a strong definition, so that we really can get better data on this population of kids, which allows us to get look at more appropriate quality metrics and ways in which we can improve care for this population of children. Moving to the next slide. There isn't a whole lot of information available right now on implementation since the bill was just signed by the president a couple of months ago, but this is kind of how we see it playing out over the next few years. The most important point, though, is that the states will not be able to opt into the health homes until October 1st, 2022. So that is, a few years from now, and the reason for that was really just because the cost of the bill, as the Congressional Budget Office looked at the state incentives and what those would cost, they were trying to, the Hill champions were trying to make sure it had a reasonable cost. So the implementation was put out a few years. But on the good side, this allows us time to implement and to work in the states and locally and also with the federal government to make sure that the necessary guidance is provided, and then states can look at that guidance and figure out, is this something that they want to participate in? And also providers and other partners and stakeholders at the state and community level can look at it and have time to work together to hopefully put together health homes and work with their states to implement. So that's the kind of how we see it playing out. This year, we will be having at least an initial meeting with CMS to talk about implementation and where the guidance, there is some guidance that will be needed in some key areas. One, which we already talked about in terms of definitions, but also how will the data be collected? What would be the standards for the health homes? And then also in the legislation, which will be of interest to all of you, the Secretary does have to provide information on best practices related to out-of-state care as part of this legislation, and that would need to be provided in the year 2020. So I think that will be helpful to us all who care about kids going across state lines and making sure that's as seamless as possible. And then, of course, so 2020 and 2021 is probably when we'll see guidance from CMS. We're hoping it's more on the early side so states can have the information and those in the states and other stakeholders so they can figure out how best to participate. And then 2022, the program would officially begin on October 1st. We also, in terms of our policy efforts, obviously the Children's Hospital Association works directly with our hospitals to support their efforts. So in addition to some of the policy work we will be doing, we will be working with our hospitals to make sure that they're ready to participate in the ACE Kids if they so choose, working with other partners in the states and communities. And we did have a demonstration project that was funded by CMS's Innovation Center that was very similar in approach to the ACE Kids Act. And there's lots of lessons learned from that project on our website that you may be interested in seeing as you're thinking about this in your states and your local communities. Moving to the next slide. So where do we go from here? So right now, as I mentioned, we're spending a lot of time thanking our members of Congress. That's really important, those that stuck with it and supported this legislation. There was strong bipartisan support, and so we want to make sure we're keeping up the thank you to those members of Congress, and also we want to keep up our strong relationships with them as we may need them as we look towards implementation. Also, it gives us an opportunity to keep hitting the message of how important Medicaid is for kids, for this population of kids, but also kids overall. As you know, Medicaid policy changes often are talked about, but sometimes they don't really think about how that may impact children. So it gives us an opportunity to talk about that. Also, just stay tuned for updates from us on as we get some more information on implementation and some initial thoughts, hopefully from CMS sometime this year on their initial thoughts, so that we can be working together. And so we'll make sure we stay connected with this group and the other supporting organizations. And also, if you have questions, please let us know what questions you have, and we're happy to share what we know, and also potentially connect you with others who may be in your states and your communities, potentially children's hospitals who may be also interested in similar topics. And we'll stay in touch as implementation progresses. And we'd love to hear if there's things you're hearing either at the state level or the federal level as you all are doing your advocacy work as well. And that I think is just our last slide, which again is just another thank you slide to our champions, but also to all of you for all of your efforts that helped us get to this point. And we look forward to working with all of you on implementation. Great. So with that, I'll end my comments. Thanks, George.
Great, thanks, Amy. And this is really important for us in our community, because there are so many kids that are on Medicaid and have to cross state lines, and it strikes me that this issue and the one that Tyler will talk about, and also our own initiative, are all Medicaid related, which is really a strange animal in itself, because it varies by state so much. And with the ACE Act and with STAR, those are some things that we had some success with, but we still have a pretty full agenda with other things that we're trying to get accomplished. And of course, as all of us know, in the pediatric cancer community, clinical trials are critical for all of us. Fortunately, most kids, as you all know, who are diagnosed, go into a clinical trial. But the question for them, like it is for a lot of adults, has to do with how it's paid for. Tyler Hansen here from ASCO will go over a bill that's pending right now that we've been very supportive of, and the rest of the Alliance for Childhood Cancer, I know, is also supporting. I just want to point out before Tyler, you take off, is we also have an action alert on our website on this issue too. So we encourage all of you to go to that and to let your representatives know that you support this. But Tyler, if you would be so kind as to give an overview.
Perfect. Thank you so much, George, and thank you for your support. And I know a lot of the folks listening today have also been supportive and have reached out to members of Congress on behalf of this bill, so we really do appreciate that. I don't know, George, did you hand over the controls?
Yes, I did.
Perfect.
Hopefully it'll work. There we go.
Perfect. Okay. So I'll stay on the first slide. I guess I was just making sure it was working. So I'm so happy to be on the line and speaking to you guys about this bill. I was telling George that I've been in a meeting since 8:30, and it's an all-day meeting. So this is actually a breath of fresh air, and I'm so happy to not be in that room anymore. But the Clinical Treatment Act, the bill number is HR 913, and believe it or not, clinical treatment is an acronym. So if anything else, this is very, very creative of the bill sponsors and how they came up with this name. But the bill is led by Binray Lujan of New Mexico and Gus Bilrakis of Florida. And basically what this bill would do is it would ensure that our patients with Medicaid have their routine care costs that are associated with clinical trials covered by their insurance. So I'm going to go through a little bit of the problem that we're seeing and then how the bill proposes a solution. So currently, if you have any type of private insurance, if you decide to participate in a clinical trial, you are guaranteed to have coverage for the routine care costs that go along with your participation. And I think on a future slide, I'm going to talk about what a routine care cost is, but just briefly right now, it's any of the care costs or items that go along with just regular care. So right now we're talking about cancer care. So anything that would typically go with conventional cancer care, minus the investigational drug, that's the coverage that we're talking about here. So also, if you have Medicare, well, I'll back up and say that private insurance, that we were guaranteed that coverage through a provision that went through when the ACA was passed. So for Medicare, those patients also have guaranteed coverage for those costs, and that happened in year 2000 with a national coverage decision. So at that time, they just decided that that's something they were going to cover. So from there moving forward, all of their costs were covered as well. So the only remaining major insurer left is Medicaid. And unfortunately, if a patient has Medicaid, they do not have the same guarantee of coverage of their clinical trial routine care costs as folks who have Medicare or private insurance. And that's because there is nothing in the federal law that guarantees that coverage. Now, although there's nothing in the federal law, I will say that 12 really amazing states plus the District of Columbia have taken it upon themselves at the state level to decide that they're going to cover the routine care costs in their Medicaid programs, which is amazing. But for the rest of the folks that live in these gray states, if you're looking at the slides, there's about 42 million patients who don't have that guarantee. So we've been hearing from our providers that they're trying to get their patients enrolled in clinical trials, and they're getting a denial. And when they try to get down to the root of it, when they're calling Medicaid, they're either not getting a definite answer of why the patient is denied, or they're just saying it's denied. The patient is denied because this type of care is not under the patient's benefit. Unfortunately, that's unfortunate in general. As most of you guys know, clinical trials have become standard of care, and I'll go into that in a minute. But before I deep dive into that, I do want to define some of the important terms that we use when we are discussing this bill. So routine care costs, I did briefly mention that it's the items and services that like the state Medicaid program would typically cover for an individual who is not enrolled in a clinical trial. So if you have cancer and you're being delivered some type of cancer care, the typical treatments and items, those are the routine care costs. So that's what we're talking about here. We are not talking about the investigational drug. The investigational portion of the clinical trial is always going to be covered by the manufacturer. And that is a question that we have been getting a lot on the Hill. So if you guys are discussing this bill, and I know a lot of you are, that's an important thing to remind folks, is that investigational piece is still covered by the manufacturer. And then this specific bill is only trying to guarantee the coverage of routine care costs that are associated with clinical trials for life-threatening disease. So it has to be a disease from which the chance of death is high if you decide not to get some type of healthcare or treatment for it. So this isn't for just anything. This is really for our folks with chronic illnesses and serious diseases. On the Hill, our main messages have been just the basic truth. So Medicaid patients deserve equal access to clinical trials. Like I briefly mentioned before, our doctors have just let us know that as we move further and further and closer towards very targeted therapies, that clinical trials are standard of care, and that depending on the type of cancer you have and what drugs are already on the market, a clinical trial could be considered first line. So if a patient comes in with a very specific type of cancer, if there's not something already on the market that's targeted for that type of cancer, a provider, a doctor, whoever's treating the patient will go for what's in a clinical trial first as the first line of treatment for the patient if that treatment is targeted. Our providers have just let us know that that is the patient's best chance at surviving, and that is now the standard of care. So if Medicaid patients aren't able to access clinical trials because they're expected to pay for their routine care costs out of pocket, we are keeping about 42 million people, like I said, from accessing the standard of care and quality care for cancer and other serious illnesses. We consider this legislation common sense, and we also consider it a very bipartisan issue. And another important thing that we've been explaining on the Hill is that not only is this an access to care issue, but it is, I guess, how should I put it? I always say that it's for the good of the science. So as we get our results from clinical trials, it's very important that the diversity of our nation is reflected in the folks that are participating in the clinical trials. You all know probably way better than I do that our clinical trials are underpopulated for the most part, and even if we can fill them up, they're not always as diverse as they could be when it comes to making sure there's women, making sure there's children, and making sure that there's enough ethnic and racial minorities represented so that our results can be as accurate as possible. So the more diversity, the better outcome we get. And as I always like to say, it's for the good of the science. So this point comes up a lot for those blue states who already have coverage at the state level. And even though their state already agrees with this type of federal language in theory because they've agreed on it at a state level, we like to also explain, although your patients already are covered, this is for the good of everyone because now we're getting better results from our clinical trials when we make sure that everyone has access to clinical trials, and then I just wanted to give a big thank you to everyone, like I said, who've already reached out to their members of Congress. We know that you guys have been very involved and very active on this issue, and you've shown us a lot of support. Our next steps are, obviously, we need a Senate companion. Right now, we only have the House version. We are hoping to have our Senate leads nailed down within the next few weeks. So fingers crossed that happens and that our folks on the Hill don't get too distracted by other things that are happening on the Hill right now. And then we are also just continuing to drum up our co-sponsor list on the House side. So right now, because the bill is very new, it was originally introduced at the very end of last Congress, so I think in November of last Congress, and now has been introduced this year. We're starting from the very bottom and working our way up to build a co-sponsor list. So we have just 10 folks on the bill right now, but we'd love to see it grow way larger than that. In particular, we're looking for more Republican members to be signed onto the bill to make sure that we can show the committee that this really is a bipartisan issue. One of the leads, Ben Ray Lujan, has said this is one of his 2 top healthcare priority issues, and he is on energy and commerce, so that's a huge deal. We're trying to see, and he is trying to see, if there's a possibility of it moving with something else that's going through the committee this Congress. So it really would help if you guys continue to show your support and let folks on the Hill know how important this is. And encourage them to sign on to the bill. And then with that, I will just say thanks again, and I will pass it back to George, and I'm happy to take any questions at the end. Thank you.
Great. Well, thank you very much, Tyler. And yes, this is very important for our community. We've been, as I said, with the Alliance too, pushing this pretty vigorously, and we have an action alert on our website, and if you will, just please, we really encourage all of our supporters and advocates in the community to weigh in on this and express their support, because it is important. One of the, as I mentioned, so many of these issues cover Medicaid now, and Medicaid is so important to our community. We've had, as all of you in the community know, great success over the last couple generations with improvements in care and survivorship for childhood cancer. But of course, as we all know too, it's come with a lot of late effects and consequences. And to be able to manage that, the transition from the cancer treatment experience to the kind of survivorship experience and the rest of life, that transition in care has become all that much more important. And it's really become one of the biggest challenges, I think many people would agree within the community, about how we manage cancer treatments in the long term. So one of the things, when the STAR Act was passed, there were a couple of provisions that were dropped in the interests of kind of compromises and clarity in the final product. One of them was a GAO, a Government Accountability Office, study on kind of financial issues. We at Children's Cause and a couple of other groups managed to get that reinstated, and just from Congress asking the GAO individually to do it, and that is ongoing. But also what was dropped was a survivorship kind of demonstration project. So we, Children's Cause, have started another initiative that creates a series of kind of child. Let me move on to the next slide here. Sorry, trying to mess with the slides. So we started something, an initiative, a series of childhood cancer demonstration projects that's really in the Medicaid program again. We're calling it the Child and Survivorship Transition Model, CAST. And it's really in some ways kind of a continuum of what's going on at NCI right now with their studies to try to identify the right interventions for transitions to care and for monitoring. So this would be made up of several different components. One of them is a treatment summary and survivorship care plan, which is often done now at most major institutions. But the question is, how is that communicated to primary care providers? Because that's where it really needs to be followed. So it provides, these demonstration projects would provide a 6-month benefit to patients to have their care plan coordinated with primary care or what other providers they may have. It would also provide a payment to the oncologist and the primary care team to kind of incentivize that process. And it would include a kind of a data collection, obviously, to find out how well each of these demonstrations is doing and what is the best method for doing it, or combination of methods. And importantly, I think it would test kind of integration of what these demonstration projects do with electronic medical records, because those are they're important, and they're increasingly important in trying to navigate the different types of providers that patients have to see now. And as childhood cancer survivors progress through their lives, they're going to see probably many providers, and they need a means of transferring and communicating that, what their experiences have been, and what kinds of things they should be looking for depending upon their treatment. So we've been talking to several members of Congress and the administration about this project, and it could be the form of either a bill or a project at CMS itself. But really, the overall goal is to find out an effective transition model to go from active treatment to survivorship, and really take these demonstrated interventions that can be monitored and implemented for patients as they go about their lives. And along those lines, one of the things that has really inspired us, and we've tried to try to keep in mind as we kind of craft this is that one of the more innovative and respective programs that's been in use in the community over a number of years now is called Passport for Care. And it's in wide use in different parts of the community, mainly in major medical institutions that treat children. But it's really served as a model that's admired by a lot of people, professional and the patient community. And so joining us today is Dr. Monica Gramatkes of Texas Children's, where Passport for Care was developed and it's still supported there. And she can give us a description of its use and try and give us some idea of how we could use it as a demonstration for these demonstration projects and how we might model it. So Monica or Dr.
Great.
Gramatkes?
Thank you so much, George, and I sincerely appreciate the opportunity to speak with everyone today. I just briefly introduce myself. I'm a pediatric oncologist. I engage in survivorship care for childhood cancer survivors, and that's kind of the bulk of what I do. My relationship with Passport for Care is I'm currently at Texas Children's Hospital, Baylor College of Medicine. That's my primary institution. And I serve as the liaison for Passport for Care for the Children's Oncology Group, which, as many of you know, is a national consortium that we all adhere to in terms of protocol development and treatment of childhood cancer. The Children's Oncology Group also is the group that develops our long-term follow-up care guidelines, which are evidence-based. So my job is part of my job is really to be that liaison from the Passport for Care team to the Children's Oncology Group and the long-term follow-up guidelines, and disseminate as much as I can this very valuable tool. Also, I think George mentioned, I think we all know that the majority of survivors of childhood cancer suffer late effects, at least one late effect. I think it's really important to consider that although the perception might be, and it's in fact true, that fewer children are diagnosed with cancer than adults that are diagnosed with cancer, so the population is relatively smaller. A child who survives cancer has a lifetime of risk for late effects from that cancer therapy. So the number of life years of that risk has significant impact on their health and on their medical needs, and just generally their community and how they live their entire lives to the time when they're 80 or 90 years old. So we're talking about a fewer number of people with a very long and lifelong impact. We are now seeing, now that these children are surviving and they're also aging, we now know that the majority of them also have a severe, disabling, life-threatening late effect, and that number is 80% of survivors over the age of 45. So these are people who have significant medical disabilities as a result of their childhood cancer therapy, and that's something that's very important to address. We also know that there are significant barriers to survivorship, which is what prompted Passport for Care. If you're diagnosed with cancer as a child, chances are you're not going to remember when you're in your mid-20s and 30s what treatment you received specifically. You may not even remember what your diagnosis was. This is a major problem. You may not know, if you were diagnosed at 2 years old, your parents may know, but you may not know or understand what your treatment was and what your risks are. There are also, of course, issues with transition, and as children grow into adulthood, they are followed by primary care providers who have no connection or relationship with the primary cancer treating institution and may not know or understand what your risks are, even if they knew the drugs you were exposed to. So there's a definite need for a survivorship care plan that transitions from childhood into adulthood and carries the information that's necessary to understand the risk that these children have as they grow into adulthood. Passport for Care was developed for that reason. So what is it? It's an online resource for survivor outreach and education. We developed Passport for Care in collaboration with the Children's Oncology Group. As I mentioned, we have long-term follow-up guidelines that are evidence-based that have been revised every 3 to 5 years for the past 15 years or so. We just did our most recent revision. It's a huge amount of work involving a huge amount of literature review and understanding of what are the most current understanding of risk and need for surveillance. The Passport for Care gives every survivor a personalized survivorship care plan. And that includes the key elements that are recommended by the Institute of Medicine. So we give them a diagnosis and treatment summary. We give them their exposure-based risks for late effects. So depending on what drug or how much radiation they received and to where, we can tell them exactly what their estimated risks are based on those exposures. And then we also give them their surveillance recommendations. So what follow-up do they need and how often? How often do they need echocardiograms? How often do they need pulmonary function tests? And specific recommendations for how often they should be seen. These are all based on their the latest information from their exposure that they received as children. So these are all derived from, as I mentioned, the evidence-based long-term follow-up guidelines. And what we have two essential ways of disseminating this information. We have a clinician portal where the medical provider can input these data and get the survivorship care plan that they can then provide to the survivor. And we also have a survivor website where the survivor can log in and see their survivorship care plan. It essentially mirrors the clinician view, and it gives them additional resources and access as well. So I'm mostly going to focus here on the survivor website because that, I think, is the really key benefit to this resource. And I think, did I miss a slide? George, can you go back one, or can I go back one?
Yeah. Oh.
I think it's going forward, but not reverse.
Okay.
There we go. Okay. Thank you. So in terms of the features of the Survivor website, so what we have is a mobily accessible resource where a survivor can log into the website from their phone or their computer. They can see their survivorship care plan and exactly what is needed in terms of their surveillance needs as well as their estimated risk. They also can see links to federal and nonprofit-based resources that include opportunities for further education and advocacy training. We offer them links to available financial and legal resources. We offer them scholarship information because there's a lot of scholarship information or availability for survivors of childhood cancer. We also give them access to blogs and survivor spotlights, particularly survivors who are medical providers in nursing and in the medical field who had a diagnosis of cancer as a child and have gone on to dedicate their lives to helping other children who've been diagnosed with cancer. So we do a frequently asked questions that leverages a lot of the information through the Children's Oncology Group that's been made available, and then also research opportunities. So we want to link up survivors with potential opportunities to be involved in research. We have a number of ongoing, even interventional studies for survivors through the Children's Oncology Group, and we want our survivors to be aware of those opportunities and to ask their doctors, how can I help and how can I be more involved? Lastly, we've developed a search tool that allows you to plug in your risk and then get an estimation for what that, or your exposures as a child, what specific drugs or radiation that you received, and get an immediate output of what your risk associated with that exposure is. As a way to answer questions, we get a lot of curious questions from our survivors of what if I had radiation to my head? What does that mean for me in my lifetime? What are my risks? And with this tool, you can ask that question and get an immediate response. And then if I click forward, let's see.
There we go.
There we go. In terms of accessibility, we offer the Passport for Care website in both English and in Spanish. We offer it free to any institution, any survivor. This website was supported through CPRIT, the Cancer Prevention Research Institute of Texas, and that's kind of what's funded the building and initial development of the website. It is now being supported through private funding as well as some national resources. It's currently in use for over 4,000 survivors of childhood cancer worldwide, and that's just the survivor website. The clinician version, the one that the medical providers use to input treatment exposures and get a survivorship care plan, is in use for over 20,000 childhood cancer survivors worldwide. But the portal that survivors see has more recently been developed in the past few years, so it has fewer participants. We also are considering a number of future initiatives. You can imagine the potential for this tool. We're essentially providing survivors a passport they can carry with them to their primary care provider, no matter, or subspecialty doctor, no matter how old they are, where they live. they can access their diagnosis and treatment information and what their recommended surveillance is, as well as their estimated risk, and give that to any of their doctors, regardless of that doctor's ability to access their primary oncologist. So this has been a big, important move for empowering survivors to take control of their understanding of their late effects and risk and provide that communication to their primary care physicians. So for that reason, I think it has a lot of potential for healthcare transition. It also has a lot of potential for adaptation and use in low and middle income countries, and we're working on development of extending the Passport for Care to our global partners in Africa. We consider the content, which was initially developed based on survivor input, as a baseline of what we want to have available, but there's a lot more that we have planned that we want to do and to include in this website, so we can potentially even continue to modify health behaviors in our survivors. And then, of course, there's a lot of potential for technological innovation to further facilitate its use and research applications leveraging patient-reported outcomes. So as to close, I just have a few slides of kind of what, so you can see what this website looks like. And I've clicked forward and I'm waiting there. So now you can see this is the intro website that you see here. Anyone can access this. You don't have to have an access code or be a part of Passport for Care to see the content. Any survivor can access it. Any medical provider can access it. And again, it's free to anyone who wants to use it. There's no charge associated with this. This is an example of the survivor spotlights that we have included in the website. We also include what to expect when coming off cancer treatment in terms of how long you have been a survivor, and more links to the research that we have ongoing through Children's Oncology Group. And then I think that's all I have. So I'd be happy to also take any questions about this.
Great. Thank you so much, Doctor. That concludes the presentations, and I think right now we'd like to just open it up to any questions that might come in. If you want, you can type in a question on the right in the box provided on the screen, and we'll wait a second. One of them came in earlier was not a question, but a point of clarification. The STAR Act authorization had $30 million for all sections of the Act. I'm sorry if I gave the impression that it was just for one particular provision, but it is for the whole, all parts of the Act. That will be, it is, of course, dependent upon both Congress appropriating it and also the NCI actually providing the funding for those, whatever the provisions are in it. But that is true. It's $30 million for the entire Act. One other question, I'm waiting for some others to come in. Monica, I wanted to ask you, you and I talked before about some other technological that you just mentioned now, but technological innovations that you're looking at, and I'm just curious about. You had mentioned trying to integrate it more with primary care providers in some way, and of course, obviously a great way would be through electronic medical records, but that's a huge challenge in itself. So what were some of the things you were looking at from how to facilitate that?
Sure. I mean, we've had a couple of different ongoing efforts to streamline the data entry component, because one of the barriers, I think, to developing the survivorship care plan, even in Passport for Care, the algorithms make it easy in terms of once you have the data, you can easily output the risks and the necessary surveillance. But the barrier is just the time in inputting the data. So all the different drugs that the patient received and the radiation exposures the patient received, somebody has to actually enter that data. So we have been working with Epic, particularly one of the electronic medical record providers, to try to develop a tool to directly import the data from the EMR into PFC. So that we've been in discussion with them for about a year to do that. I think Epic has some interest in survivorship care plans and wants to partner to do this. That is one effort to try to make it easier on the upfront end and data entry standpoint. From the transitional care perspective, we are in process collaborating with our Baylor Transition Clinic as well as our local pediatric providers to develop tools within our electronic medical record system to directly set up a line of communication between the primary care provider and the oncologist, the pediatric oncologist provider. And that really has been, we've considered potentially giving primary care providers access to Passport for Care, but we think what they'd likely prefer is a abbreviated version of the most common associated risks and the particular studies that are needed to be obtained for surveillance, as well as a direct line of communication with the oncologist provider. You can imagine the primary care doctor has a number of questions for the oncologist that comes to us through various ways. When can we revaccinate? Our patient has a rash. Could this be part of their cancer late effect? There's a new lymph node that we're worried might represent relapse. What should we do? And we really want to facilitate that. So we're developing a communication tool that will help those providers directly be able to connect with our oncology provider team. That doesn't involve multiple lines of communication, but basically one track with our pediatric associates. So I think there's a couple of different things we have in process, and those are a few of them. We're also trying to streamline a package of information that we can distill down to the most key points for our primary care providers so we can move the survivorship care plan, which is a lengthy document, and distill that down to a few key points that need to go out to our primary care doctors.
Yeah, that's great. That's encouraging to hear, especially working with a firm like Epic too, because that's they're so widespread and dominant within across the medical community, and particularly because primary care providers or pediatricians probably, from what I understand, very infrequently see cancer survivors. So it's something that they're not really familiar with. So they need that ability to go back and get the expertise from the oncologist.
Yeah, I think it's unreasonable to expect a primary care doctor, a pediatrician, or a family practice doctor to have the same level of expertise that an oncologist would in taking care of a survivor. They haven't been trained to do that, but I think what we've seen in transition of care and survivorship is that a shared care model really provides benefit to both the primary care doctor and the oncologist. The oncologist needs the primary care doctor to manage the chronic health conditions that have resulted from the cancer therapy. They need the primary care provider to obtain the surveillance testing. The oncologist doesn't have the bandwidth to see patients frequently. We see them on an annual basis once they become survivors, long-term survivors. And we need to have that management that happens for all the chronic health conditions that require more frequent follow-up. The primary care doctor needs the survivorship or the oncologist's expertise in determining what is a late effect, what are the risks to watch out for, and what surveillance is needed. So really, it's a multidisciplinary collaboration. We need to do it together. We can't do it separately.
Right. Absolutely. Yeah, Amy, if you're still on, if I can go back to you about something. I'm curious about whether the ACE Act has something about transitions if a kid and their family goes across state lines for major treatment at a major medical institution like your members are really. Is there provision for how they're kind of transitioned back to their community, or is that yet to be worked out with CMS in terms of the rulemaking?
Well, I think the vision is that the health homes would be working with the children and families to make sure as they have to go across state lines that the care is better coordinated and supported. And when the child, the specific example you are giving, as a child comes back, to make sure that there's communication among the providers and that there's support across the board of the health home, better supporting that child and family. The ACE Kids Act won't fix all of the issues with out-of-state care, but it should help with providing better coordinated care and better supports when the child comes back home.
Mm-hmm. That's good. That's good to hear. That's great. Well, I don't see any other questions at the moment. So I just want to take a moment to just thank all of you. Amy, Tyler, and Dr. Gramatis, thank you for contributing your time and sharing your thoughts and experience and expertise with us. And I want to thank all of you who have been on the line for your interest and support for our mission, which continues to be curing childhood cancer and making sure that survivors have long and healthy lives. If you will, if you could take a moment afterwards and complete this, the post-webinar survey, which you'll automatically be redirected to. We really appreciate the feedback. And if you could, if you'd like more information about this session or about any other legislative or advocacy efforts that we're involved with, please visit our website and you can send us a message at info@childrenscause.org. As I mentioned at the outset, we do these webinars on a quarterly basis and bring you different types of topics that we hope will educate and energize you in our advocacy efforts. So we'll hope you'll join us again. And until then, thank you all very much and have a wonderful and cool summer. So thank you very much. Take care.
Thank you.